Rehabilitation goals for return to sport following knee surgery include range of motion, muscle strength and endurance, neuromuscular control, and restoration of normal joint kinematics during functional activities. Single leg squatting is a closed-chain activity that involves the knee and surrounding joints and can be used as part of functional testing to evaluate muscle strength, endurance, power, and movement quality. As such, the single leg squat has been utilized in my clinical setting as part of a battery of functional activities to validate readiness for return to sport. For the purposes of this discussion, I will provide a comprehensive, qualitative, anatomical analysis of the single leg squat. A simple table is helpful for observing the various movements, muscle groups involved, contraction types, and force requirements at the joints involved. The sequence of movements for this activity involves a down phase and an up phase in which the individual lowers themselves to a predetermined depth, changes directions, and returns to the starting position. The starting position is determined by measuring a 30-degree angle of the knee joint relative to the anatomical landmarks of the hip and ankle, greater trochanter, and lateral malleolus respectively. The down phase is complete when the knee angle reaches 60 degrees relative to the same adjacent anatomical landmarks. One full repetition is achieved when the participant performs one down motion and one up motion. For the scope of this discussion, the segments that move and joints involved during this activity will be isolated to the hip, knee, and ankle. During this activity, these three joints operate primarily in the sagittal plane about the transverse axis, moving into flexion, extension, or plantar flexion and dorsiflexion. The hip joint starts in a slightly flexed position from neutral and moves into a more flexed position as the participant performs the down phase of the activity. When the participant reaches the end of this phase, the hip is still in a flexed position relative to neutral and extends back to a slightly flexed position during the up phase of the activity. The knee joint starts in a slightly flexed position, 30 degrees, and moves into a more flexed position until reaching the end of the down phase at 60 degrees. At this point in the activity, the participant changes direction and the knee joint extends until returning to the original starting position where the knee is slightly flexed. The ankle starts in a slightly dorsiflexed position and moves into more dorsiflexion as the participant performs the down phase of the activity. Upon reaching the end of this phase, the participant changes direction, the ankle plantar flexes until the up phase is complete, where the ankle is in its original starting position of slight dorsiflexion. The active muscle groups during the single leg squat are the hip extensors, gluteus maximus and hamstrings, external rotators, piriformis, gemellus superior, obturator internus, gemellus inferior, quadratus femoris, and obturator externus. Hip abductors, gluteus medius and tensor fascia lata, knee extensors, quadriceps femoris, knee flexors, hamstrings, and ankle plantar flexors, gastrocnemius and soleus. A combination of eccentric, concentric, and isometric contractions occur during both phases of this activity. During the down phase, the primary active muscle groups of the hip, knee, and ankle joints contract eccentrically to lower the individual in a controlled fashion, resulting in a net decrease of mechanical energy. When the individual changes directions and ascends, the same primary active muscle groups contract concentrically to create motion in the opposite direction of the down phase. Throughout the entire motion, the hip external rotator muscle groups and hip abductors must isometrically contract to limit motion in the transverse and frontal plane respectively. Relative to the knee, the quadriceps femoris group create force upon the tibia via the patella tendon across the knee joint. During the squatting activity, the patellofemoral forces can be up to 7 times the individual's body weight. For the 90-kilogram person performing the single leg squat in this video, his compressive forces are approximately 5,000 newtons per repetition. Based on the high level of forces associated with this activity, the importance of correct technique should not be overlooked. Current research supports the implementation of a generalized lower extremity strengthening program for correct kinematics of the knee. Poor hip muscle control in the frontal and transverse plane can lead to performance decline and potential heightened risk for injury by causing dynamic valgus motion at the knee. This video is demonstrating what can occur with decreased hip extensor, abductor, and external rotator strength. Valgus moments at the knee can lead to increased stress of the medial structures of the knee, lateral meniscus of the knee, and have been found to be a mechanism of injury for the anterior cruciate ligament. Additional consideration should be taken to ensure correct ankle mechanics. Sagittal plane displacement, specifically knee flexion, can be greatly affected by limited dorsiflexion of the ankle during the single leg squat. Some corrective exercises for strengthening of the gluteus maximus and medius are forward plank with unilateral hip extension, side plank, and side plank with unilateral hip abduction. External rotator strength can be achieved by performing the exercise demonstrating here. Side-lying clamshells isolate these muscles and can be advanced by adding cuff weights or resistance bands around the knees. The quadriceps femoris muscle group can be isolated by performing single leg press motion. Both concentric and eccentric strength is achieved on this machine. Finally, single leg heel raises isolate the plantar flexors of the ankle.